just as helps us with our minutes and things of that nature. So we do have a busy meeting today. I want to first call on Lee Dobson, who up until yesterday was our Secretary Treasurer. She is now the new Vice Chair for the coalition. So Lee, I'll call on you.
Well, thank you, Mary. And yes, we'll provide an update on the finances. We had a board meeting yesterday and reviewed our budgets to actuals, and everything looks great. We're a little bit lower than expected in our membership, and I think that's partly because of how organizations renew. While our cycle is January through December, some organizations renew during the year, and so we'll work with organizations, but we'd like to keep the cycle as January through June. No unusual expenses, and did I say January through June?
Right.
January through December. We do work all year long. So if you haven't renewed, please do so. And if you need an invoice, Sandra will be happy to send those out. But we're on target for ending at the end of the year in a favorable position. And our annual conference was probably the largest expense that we have, G&A expense outside of personnel. And that was a good event, especially with the sponsorship and donation from the Division on Aging. We really thank and appreciate their support. So we're on target and no unusual expenses.
All righty, very good. Thank you, Lee. Any questions relative to budgets or anything like that? And we will be talking a little bit later in the meeting about a couple of grant applications that we've got out there too, just to let you know what's going on with that. Also, you were sent a copy of the minutes from our August meeting. Our September meeting was our annual meeting, but you will have those. Those minutes will also be posted on the website for the coalition. So appreciate that. Next, unless anybody has any questions or anything. Okay, I don't see any hands up. Do you, Sandra? Okay, all righty. Well, we're going to start off today. Just a little bit about our agenda today. So we have the state health director who is coming to be with us. He will not be able to be here until 11:15 because he's got another meeting this morning. So we're kind of not want to say flipping our agenda, but we're doing a lot of our business and hearing from folks prior to him being here. So at this point, I'm really excited to introduce Teresa Troop, who many people on this call know Teresa for many, many years. She has been a mainstay in the Aging Network for a long time. She was a long time executive director of the North Carolina Adult Day Services Association. And during that time that she did that, she also for 10 years was executive director of the National Adult Day Services Association. And she took a little break for like 6 to 7 years, Teresa, I think it was. And she actually moved to Franklin County and has been doing lots of things local. I think she works some with Duke University health system also, but she's been really busy. But they recruited her, and she said yes and came back as a new executive director again of the North Carolina Adult Day Services Association. So each month we do a profile of a member, and the Adult Day Services Association is certainly a longtime member of the coalition. So we wanted to hear from Teresa, welcome her back, but also to hear more about the Adult Day Services Association. So Teresa, turn it over to you.
Thank you, Mary. I'm on the Mary Bethel plan in case any of you are interested in. If you think you're going to get away, you'll be back. So just a warning. Thank you for allowing me to share today. Adult Day Centers opened as early as the early 1970s, like 1972, 73 in Greensboro and Durham. So for those of you who aren't familiar with it and think it's a new service, it's not. We actually have 3 centers in the state of North Carolina that are celebrating 50-year anniversaries this year. So it's been around for a while. And because of that, the Adult Day Services Association, which is a nonprofit trade association, which is governed by a board of directors and bylaws, it formally organized in 1978. Our primary functions are advocacy, regulatory, support, education, and training. In North Carolina, adult day centers can legally serve adults who are age 18 and over, and some centers only focus on certain age groups. That previous slide, please.
Teresa, while you're at it, can you, and you may be doing this in your presentation, but tell people what adult day centers are.
Yep, I'm gonna,
You gonna do it? Okay,
yep, it'll come up.
great.
So some centers focus on certain age groups, like only senior adults or people who are living with certain chronic conditions or specific diseases like dementia or intellectual disabilities. The adult day centers are certified annually by the North Carolina Department of Health and Human Services Division of Aging, and they're monitored by the county departments of social services and the health departments if they are health centers. There are currently 92 certified adult day centers in North Carolina. That includes 14 PACE sites, and those are required to be certified as health centers. That's among 46 counties. The maximum capacity among those certified centers is currently 5,644 collectively. That's how many participants, or we call them participants, who can receive services in a day. Adult day centers are required to operate 5 days a week, at least 6 hours a day. But in order to meet the needs of the working caregivers, centers on average are open 10 hours a day. So that is probably news to a lot of people. They can be certified as social models. They might be a health only model or a combination model. I think there's one home also in the state. And the health centers have a nurse at least 4 hours a day on site. So staffing requirements are depending on the certification, but in a social model, it's a 1 to 8, or in a combination 1 to 6, or in the health centers 1 to 5. So these are community-based programs. At the end of the day, the people who go there to receive supervised care go back home or wherever they live at night. And I'll show you in the next slide some of the people who are served there. So I was the executive director of the Association of North Carolina's Association for 23 years until 2018. And then I returned in April, as Mary said. During my absence, there was no statewide data collection. So this graph is from 2022 national study, which is, it's now been renamed as the National Post-Acute and Long-Term Care Study. So one of our priorities for 2026 is to update data on all of the certified adult day centers across the state so we can better capture what services are being provided, who's being served. But you can see in this slide, there are a variety of chronic conditions that are being managed in these adult day programs. And I had the pleasure of meeting yesterday with the coordinator for the North Carolina PACE Association, and I call them adult day on steroids because they have a higher level of professionals who are delivering care, and because they have to have the therapists and some doctors and some others. But I just, it was interesting as I was talking about what are the conditions of the people. It was very, very similar, the people that in just the adult day programs in the communities that are not PACE sites. So the people who are attending, the participants generally attend 2 to 5 days a week. And there are some centers that do operate on Saturdays as well. And in the next slide, you'll see the actual services that I was referring to, serving these people who have the chronic conditions. Although the general public kind of misunderstands a lot of times, they don't understand what's the difference in an adult day center and a senior center. for me, the differentiator is really supervision. If you need supervised daytime care, then an adult day program is the place for you to be, as opposed to a senior center. A lot of times the people are driving themselves there, or they might ride a bus to the nutrition site and that type of thing. They are not supposed to be requiring supervised care in the senior centers. So some of the organizations that you guys are operating are really companion services to our centers, because at the end of the day, as I said, the people are going home and or wherever they live. It might be that they're getting home care in the morning to get them up and ready to go to the day center, and then in the evening they're using that service. They may have weekend respite in some of the, or even short-term respite in some of the long-term care facilities or residential facilities. And so there are a lot of different programs that we're all trying to serve the people. And so it may be very common that if a person is not attending a day center 5 days a week, they might be getting home delivered meals, because that's a very important component of their services as well. So a little on the next slide, you'll see something just about some of the possible funding sources that adult day centers have. Private pay is always ideal, but like any business, adult day centers really have to diversify their funding in order to operate successfully. Everybody in this group and across the world knows that COVID has really changed the way everything is happening, and it's making it challenging for some centers that accept Medicaid Cap DA particularly to continue accepting that payment source, because the cost to do business is anywhere from $75 to $100 a day. And because we've got the nurses and all of the wages have been expected to increase since COVID, cost of living has increased, food costs have increased, so many things have increased, and yet those rates, particularly for us, have not changed and have not changed enough. So when you're looking at about a $40 per day reimbursement and your cost to provide care is more than double that, it's a challenge. So we really value all of the support that everybody who was joined with us with the direction of Lee and the other groups who coordinated our efforts at the legislature earlier this week. We really appreciate being able to take a stand. The 3% cuts are going to take away from that reimbursement that we have. So it's a challenge. It's a tough time, but we value being able to be standing alongside all of you guys and to just work together to improve the quality of life for the seniors in North Carolina. So that might not have been as much detail as you wanted, but ask me some hard questions.
Yes, well, thank you, Teresa. Great job, great overview. I'll ask the first question, then open it up for everybody else. So, I've been at this business a long time, and seems like I remember, like back in the 90s, the early 2000s, I think there were over 100 adult daycare centers in North Carolina. Is that still
You're correct. It got up to about 120 something. Yes. And so some of the trends that I have seen are that a lot of the centers started out as social model programs. Respite programs are not required to be certified if they're not getting the funding. And so they are not providing the personal care, doing medication administration and that type of thing. So social models in churches were pretty common. And now there's a significant change towards more health services are really being required, because we're serving people who need more care, and families are waiting longer to access the services. I spent some time working in administration and assisted living, and one of the things that I saw there as we worked closely with some hospice organizations was we were always saying that families wait too long. They could really capitalize more services and benefit more if they would access them sooner, and people could probably stay at home longer, but for whatever reason, they're not doing that. And so as the cost of healthcare has risen and people have, maybe they're tired from the COVID care at home, but they seem to be trending away from, we don't have the long stays that we used to, or not as long as we used to. And so, and PACE is growing across the state. They're expanding in their territories, but they are also trying to expand to be able to have some PACE alternative sites. And so they too utilize adult day centers.
Teresa, just for people who don't know, tell them what PACE is very quickly.
So PACE is a program of all-inclusive care for the elderly, and people have to be what we call dually eligible, Medicare and Medicaid eligible to be able to use that service. And they're only in, they have certain territories or zip codes that they are, that would allow them to be eligible for the service. But their intent is to keep people in the community for as long as possible, just like we do. But they also have, and if somebody else is way better spoken on PACE than I am, but they
it's a
they
funding
pay
model
for like nursing home if it gets to the point that the person needs to be in that, they will cover that cost as well.
Yeah, PACE ends up being combining Medicare, Medicaid funding, and they are responsible, as you said, for the person's care. I see a note in the chat from Rebecca Freeman with Division of Aging. She says, Teresa, feel free to put in a plug about the training conference, details to be determined. Do you want to mention that?
Absolutely. Thank you, Rebecca. So we are working closely with the Division of Aging, the North Carolina Adult Care Association, which are, we call them the monitors of adult day programs and PACE programs across the state. And just trying to get back on track since post-COVID and everything, in providing a training, statewide training for all of the DSS monitors and all the adult day providers, the AAA folks who do regulatory oversight, as well as PACE, the VA, anybody who is involved in adult day from a regulatory standpoint, or providers that is coming. We're hoping it's going to be sometime in late March, but we're all working closely to kind of make that happen. And so more details will follow. We're looking for a site now that will accommodate everybody, and something that's cost effective, because we know budgets are tight.
Great. I see Gina Upchurch, you have your hand up.
I do. First of all, Teresa, thank you. Yeah, for stepping back in. And yeah, we've got to, you don't know where you're going if you don't know where you are, right? So
That's exactly right.
Yeah, thank you so much for doing that work. And for your dedication to the state of North Carolina. Just two quick questions, and you may have said this and I apologize, I missed
That's
it.
okay.
Can you talk about the payer mix? Like, I know the VA pays, Medicaid pay, what are the rates that people are getting for the social model and or the health model? Is it enough? Is it not enough? Do they have to subsidize it with private pay? Can you talk a little bit about the funding? Because there's somebody who's now paying for 24/7 care for a parent. Well, my father's helpful, still paying for it, but it's so cost effective. I mean, I'm assuming I could pay a lot less if there was, if he was in adult day, and he has socialization. There's so many positive things about it. So can you talk a little bit about the payer mix and how it's shifting and where the money's coming from? And
Absolutely.
Yeah, thanks.
So, so like any business, you have to know your unit cost in order to be able to operate. If you are not charging what it costs, let's say it's $75, that's just a number I'm throwing out there. If you're only getting, and I'm going to pick on CAP, because the Medicaid cap, because that's what we are passionate about right now with the General Assembly, and it's top of mind for us. So that reimbursement rate is around $40. If it's costing $75
day, are you talking per day or per hour? I mean,
per day.
Yeah, no, yeah,
per day. So we're required to provide 6 hours of care, But in order to meet the needs of the working caregivers, the average is 10 hours a day. So you take that 10 hours and you divide it by, let's say, the $40, and you see, how do you provide nursing, a nurse and the direct care workers and breakfast, lunch, and afternoon snack and whatever activity supplies for that's, working out for $4 an hour. It's just not doable. So it's up to the adult day center and their supporters to make up that difference if they accept that funding source. So what is happening is some centers have chosen and are going to be choosing or making that tough decision of, can we afford to continue with that funding source? And so that's for the Medicaid cap DA. Some of the younger,
Just to clarify, that's social and or health model or both?
that is a health model.
That's so you get more generally for health model or not really?
Every business sets those rates for,
Okay.
so they set the rates, but we don't set the rates. The CAP DA, the community alternatives rate, that is not a negotiated rate for us.
Okay.
And that rate has increased a little bit, like when I say a little bit, maybe $1, and then they'll come back and take it back. And so you can imagine why that is, 3% cut is big, but we need it to go way farther just to be able to continue serving those folks. The VA does reimburse, and that is a negotiated rate between the center, and part of it depends on what that veteran needs. And so generally that is a health model center also. And when I say health in these terms, I'm talking about, if on paper it's either combination or health, but if they have a nurse there and they're certified to be providing those health services. Their home and community care block grant and state adult daycare fund are two other funding sources that are government funded. And fortunately, in the recent years, we were able to, with much support from all of you represented here, be able to get, there was a capitated rate on that as well. And it was like $30 some a day. And so now, fortunately, that is a negotiated rate. But as all of you know, the pot of money is, especially for the home and community care block grant, other services are funded through that. And so we need those pots of money to increase so that everybody can continue to serve more people, because North Carolina is a retirement state.
Yeah. And you said the state block grant. What was the other thing you said?
State adult daycare fund.
Oh,
so the state adult daycare fund with home and community care block grant, you have the age limit. It's only for the older adults. I believe it's 60 and over. You guys would be more schooled on that because I've been out of it a little bit, but or the caregiver has to be that age. The difference in that and the state adult daycare fund, the state adult daycare fund was established many years ago, and a lot of the providers don't even know about it. And that's because when it was established, it's, I would say, roughly $2 million. And that was in the 1970s. $2 million in the 1970s is a little different from $2 million today. And so that pot of money has not increased since then. So you can imagine why we value the collective spirit and support of all of you working with us to try to change those things, because they can't afford, and we can't afford, a full-time lobbyist somewhere. I mean, we advocate, we're very grassroots, but at the same time, you've got people who are working in the centers trying to keep people managed and safe while everything about life is still going on while they're in the center. So that's why I went and represented them with a student intern earlier this week, because they just can't go out and do that kind of thing, during the week.
Thank you, Teresa. I don't see any other hands up with questions. Anybody else have one? Well, I think what you very ably pointed out, Teresa, is the critical role that adult daycare and adult day services and adult day health services plays in the continuum of care in North Carolina. I think you've also pointed out the fact that if we want this model to be sustainable, then we need to look at how we can get more resources in there. You're right that state adult daycare fund has not been increased in, decades. And families pay lots of times a lot of out of pocket for services and things too as part of that payer mix. But it's a situation where we have less centers today than we did 20 years ago, because financially it's very hard for centers to keep going. So hopefully
And I'm not sure if I said it, but the state adult daycare fund can serve people age 18 and over, as opposed to just the older age restriction on the home and community care block grant. And there is a note in the comments, Glenda pointed out, PACE is for people who are 55 and older, and they have to have the skilled nursing home level of care. And so, I mean, for the money, you really can't beat it. And they're some of the most creative, passionate, and fun people, or I definitely wouldn't have come back.
Well, we're glad you did, and thank you for your years of service and for being here now too. I think it's a
Thank
very
you.
critical time for you to be with the association.
Thank
All righty,
you.
well, thanks again. Sandra, going to turn it over to you for updates about things.
Good morning, everybody. It's Friday. And it's beautiful weather and all of that good fall stuff. Thank you, Teresa. That is very good information. I know, being so new in the field of aging and older adult care issues, it's amazing what you all do on a daily basis to help older adults in North Carolina, and it's very much appreciated. As well as what Teresa said, the group working together, we all have our individual things that we do very well, but we are really strong when we all have the same voice on issues and make that heard very loud and clear. And that's one of the things that the coalition from its very beginnings was doing and will continue to do. So we appreciate your time this morning. As was mentioned earlier, we did have our coalition board meeting yesterday with our two new board members, of which Teresa is one, as well as Mike Kondratik, who's also on the meeting this morning. We had board elections for officers, and Mary Bethel was elected as our chairman again. Lee Dobson is going to be our vice chair, and Lee Little, who is with Wake County Government, is going to be our new secretary treasurer. So we're looking forward to a very good year. And I'm looking around to Teresa, when you said you're on the Mary Bethel plan, I think Janice Tyler's on that too, because she was laughing hysterically when you said that. So yeah, there. See, she's shaking her head. But that just means that you are very committed to the work that you're doing and want to enjoy what you're doing. And so that's been great to come into and to meet all of you that are doing that. The other thing, the coalition, of course, getting through the annual meeting, which was very, very successful, being my first one. I appreciate all the support that we received through that. The coalition, as I have gotten more versed in some of the things that we're doing, I actually was invited to make a presentation back in August at the Symposium for Senior Center Directors. Selena and Leslie invited me to do that. And so that was a very good, talking about advocacy. And I guess I did a good job because they invited me back to the Module 6 program for the Senior Center Directors back in the first part of October. So I was able to provide information there. So it's very good network to work with. And also kind of following up a little bit with what Lee said about the membership, with some of the changes in the executive director position here at the coalition, we have not been on top of some of the membership as far as getting notices out about when some need to be renewed. And so that will definitely be a focus starting in, starting now, but in January, you'll start receiving some information notices about that. We've got about 90 organizations right now. We at the board meeting yesterday, we were talking, we've had about 10 that have not, we had about 100 or so last year, so we're about 90. We've had some that have dropped out, others have come on new. But we definitely want to get that number up, and also our individuals to join this. I told the board that I have at least 4 friends that are going to get Christmas gifts from me of memberships to the Coalition on Aging. So, because they're all 70 and over, and so they need to know what's going on. Because that's one of the things, and I think why so many of you join us on these meetings. There's so much information with all these programs and how they're funded. There's so many layers of what's being done, and the general public really doesn't have an understanding of that. And so that's one of the things that I want to help is educate folks about that, and how we can better make older adults in North Carolina more aware of what is happening with some of these programs that they may not be using now, but they may need to use in the future, and how important it is to take charge of their care while they can. And also to educate those caregivers that, there are things out there to help them, and how we can get that information out as well. So looking forward to a great year with our new board members and the board. We had a really healthy discussion yesterday about the mission of the coalition and moving forward. And we also we're kind of waiting to hear on the Z. Smith Reynolds grant that we applied for, and also another grant with a foundation in North Carolina, which will really have a great impact on what we're able to do staff-wise with the coalition. So thank you again. And Mary, do you have anything else that needs to be added?
Yeah, I will add some things also. As Sandra said, our board kind of functions. We elect new board members at the annual meeting, and then we kind of start our board year in October after our annual meeting. So we kind of take that opportunity to just kind of reassess everything and look at what's ahead for the future and things like that. So I just want to throw out some things that we talked about yesterday. One was our annual meeting is very successful, but we're wondering with there's so many things that are in the fall. And also, I will tell you, 3 of the last 4 years, we have had to watch the weather really carefully about whether or not tropical storms or hurricanes or whatever were going to impact things. And as you guys well know, last year, 2024, our annual meeting was the same day that Helene came through North Carolina. So we're thinking about, would it make more sense to possibly look at doing a springtime meeting? But we know a lot of you also have meetings in the spring, as well as a lot of you have meetings in the fall. It was brought up yesterday that maybe if we did something in the spring, we could combine it with our advocacy day that we have. So just think about that, and we would welcome any input that you guys want to have about whether or not you think we should keep our annual meeting in September as we have always had, or would it make sense to think about having it maybe during May, during Older Americans Month or sometime like that, and possibly combine it with an advocacy day or be a freestanding event or whatever. By any means, we are not changing anything right now until we get thorough input from members and all our board members, things of that nature. But if you have thoughts on that, please send them to Sandra. And we actually formed a little ad hoc committee that will be looking at that. And in that same vein, while we are just looking at everything that we do as an organization or as a coalition, we have always, since people started meeting informally as a coalition back in the 1980s, we've had our meetings on like the 4th Friday of every month, and our monthly meetings. And one of the reasons we went to Friday is because a lot of folks that are engaged with the coalition, they work with the General Assembly, and have various roles where they need to be available to go to the General Assembly and do their jobs. And Tuesday, Wednesdays, and Thursdays are typically days the General Assembly is in session when they are here. And so we stayed away from Tuesday, Wednesdays, and Thursdays. So Friday was a logical day to do it. Well, as we have at pre-COVID or post-COVID, I'm sorry, now that a lot of folks are working from home, a lot of people are working modified schedules, things of that nature. Fridays aren't what they used to be. A lot of people don't work on Friday. Some people work Friday mornings and then take off Friday afternoons. I mean, people's schedules are a lot more fluid. What would be your thoughts relative to, should we continue to keep our meeting on the fourth Friday of every month at 10 o'clock like we've done? So again, if you have thoughts on that, if you would get those to Sandra also. We mentioned that Sandra did, that we'd applied for a Z. Smith Reynolds grant. We've talked about that in the past meetings. We will hear something about that at Thanksgiving time. So hopefully it'll be a good Thanksgiving pre-holiday gift. We'll get some good news there. We also, she mentioned another grant. We have made contact with Leading Age. They have an endowment now, and just thrown out a proposal to them also. We would like to, increase our staffing, because right now we basically have 1.5 staff positions, and that half position deals with direct care worker type issues. And that grant runs out at the end of this year. And we think if we want to do the things that we think need to be done in North Carolina relative to aging and the role that we would like to play in that, we need to have more staff. We also feel it's very important in the role that we play. Well, it's important to anybody that we hire that we have health insurance. And in the role that we play in advocating for benefits and services and supports for folks, that it's really hard for us to be a true advocate if we don't even pay those benefits ourselves. So we would like to offer health insurance if we can afford it, going forward to current and future employees. So that's has been built into the grant proposals that we have out there right now. We are really excited that we have been asked by the North Carolina Institute of Medicine, the North Carolina Medical Journal, to coordinate the authoring of an article for their December edition of the Medical Journal that's going to focus on Medicaid, a lot on Medicaid, about Medicaid home and community-based services, looking at a point in time about what do the services look like, how does it impact older persons and persons with disabilities in North Carolina. So we pulled together a group of folks that we currently are in the process of looking at how can we get together an article that actually has to be first draft in on November 14th. So we've got to work really quickly on that also. We have been real fortunate. We've got some good press coverage lately on things. After our annual meeting, we got 3 press articles about that. Max Rickman, who was the guest speaker from the National Committee to Support Social Security and Medicare, I thought did a really nice job, and I think his presentation generated a lot of interest. Also, we happened to be having our annual meeting at the same time that all this debate and discussion has been going on relative to Medicaid cuts. We have been very engaged in trying to be out there also relative to needed advocacy on this. Lee Dobson, who was on earlier, and Julia Adams, who I see on right now, they have really, really been doing an excellent job of coordinating and getting lots of providers and advocacy groups in North Carolina engaged and involved in the fact that Medicaid, with their proposal to cut anywhere from 3% to 10% of the reimbursement rate to providers for anything that's funded by Medicaid, is going to be a pretty devastating issue. Now, a lot of people think this is tied to the federal action with the One Big Beautiful Bill. It is not. This is strictly a state issue, which boils down to the fact that Medicaid said they did not have enough money to fund the operation of the Medicaid program at the rate it needs to for this next year that was appropriated by the General Assembly. The General Assembly said they would come back to the table and appropriate that additional money later. The budget folks said, that's nice, but we need to act on the money that we've got available. So those cuts from 3% to 10% went into effect on October 1st. Some providers have already started cutting services or programs or trainings or whatever they need to do to help balance the budget. We know that particularly like a lot of folks who in the developmental disability world that have direct care workers, those workers have already received a budget cut or a pay cut in their wages. Some agencies have made other cuts to programs. A lot of providers were waiting until the General Assembly came back in session this month for their mini session in the hopes that they would act and appropriate additional funding then. That did not happen. So Julia, if you don't mind, I'm gonna turn it over to you for you to say a few words relative to where things stand now and add any more background you want to relative to that. Sorry to put you on the spot. I saw you on there.
It's okay, Mary Bethel, whenever I show up, you can put me on the spot.
Oh, great. All righty.
Let me go ahead and, can everyone hear me okay?
You're fine.
Okay,
Yes.
Great. Yeah, Mary Bethel did a great job of going over what has happened. So basically at the end of the budget cycle, the first section of the budget cycle, when we tapped out at the end of June, we did not have a new fiscal year biennial budget. It does not look like we will have a new fiscal year biennial budget until sometime in 2026. I will give you an idea of what I think, looking at my crystal ball, when that process will kick in again. I think it'll be sometime in March or April. And that, right, everyone's shaking their heads. I am shaking my head right along with you. That is deeply concerning. And so we came back in July and we passed House Bill 125, which was the mini budget with the 690 million, with a 600 million in it. And then 7 days later, the announcement came on the rate cuts, the 3%, 8%, and 10% cuts. Now, I could go 100 ways on this part, Mary Bethel. The DHHS says they need the additional money. House and Senate members say you had enough to get you through April. We were still in negotiations. You should not have cut the rates. That's where we are in the same dialogue nonstop. Then obviously we came back last month and we had the House and the Senate pass another round of mini budgets for Medicaid rebates. The Senate one included money for the hospital for children, which was provided in a previous budget. This was the last tranche of money. And then the House passed what we call a clean bill. It was just the Medicaid rebates. Those bills crossed chambers. No one picked them up from the other side. They gavelled out. Come back in October, and we did have a really successful, and I mean this honestly, we had a very successful Medicaid Day of Action this week. When I showed up at the building Richard's clapping. When I showed up at the building at 8:30 in the morning, House Bill 491 was the Medicaid work requirement bill. By 10 o'clock in the morning, that had turned into a really sprawling, bizarre looking mini budget that had no Medicaid money in it. By 2 o'clock in the afternoon, House Bill 491 had become a Medicaid contingency reserve bill, which is that other lever we've been trying to pull, which basically in statute, we have 500 million sitting over there in Medicaid contingency reserve. And what we've been trying to do is tell the governor's staff, please start your process. The governor's team started that. A letter was sent out from DHHS and the Office of Budget and Management to the controller saying, kick in your pieces, folks. Make sure we know how much money we need for the budget, where we are right now, what all the audit data is. If you look at the statute, that's number 2 and number 3 on that list. But the number 1 part would be the appropriation, right? And so House Bill 491 became an appropriation bill, $190 million. However, the adjournment resolution didn't allow that to actually happen. So when the House passed the bill and sent it to the Senate Rules Chair reviewed it and sent it right back to the House and said, we're really sorry, but under our adjournment resolution that we all agreed to, no Medicaid bills can move this session. The bad part is no Medicaid can be taken up in November either if we're going to stick to those rules. So the real pressure is going to have to be on the governor of the state of North Carolina, because since this all happened, y'all know, we now have a Medicare issue as well, right? You know, there are going to be big Medicare rates coming down November 1 that are cuts from the federal government around home health and hospice, and that's going to be significant. And there's a real concern about SNAP SNAP's going to run out in North Carolina. These are services we all use as as we get older. We have a large aging population on that SNAP benefit, as well as a disabled population on that SNAP benefit. And so we've been talking to the governor. We all had a meeting with the governor's staff. There were 10 of us in the room. Lee was with me. And and so was Tim Rogers with the association. And what we asked basically was for the governor to back off, for the governor to be the hero, and to basically rescind the cuts. We're going to continue to work with the governor's staff on this because we can't go to March with 3, 8, and 10% cuts. I think Teresa did an amazing job of explaining that. Our adult day programs were already critically underfunded if we look at Medicaid, and they were already unstable, and they are a critical part of our system for our aging population. So this just adds to destabilization. Y'all know I work across this field. I mean, I work in addiction recovery policy and mental health policy and IDD. I can tell you that we have a lot of older folks living in our intermediate care facilities that can't live anywhere else. It's 24/7 care, 365, pharmacy, food. I mean, those small ICFs are going to take a big hit, and those cuts all start on November 1. So we've been seeing the Cap C and Cap DA and the aging services October 1. We'll see the rest of it hit November 1. And it's going to be a really rough time for all of y'all, for all of us, for me, as I try to explain this on every call I get on.
And this is before even the federal. This is before even the federal impacts of the one big beautiful bill come down the pike.
Absolutely. This is before the effects of HR 1 even show up. And, with HR 1, when we talk about SNAP benefits, right, states are going to have to incur more cost on SNAP when HR 1 comes. There are Medicaid cuts in that HR 1 bill. There are requirements for work requirements, which is going to put in huge stress on the Department of Social Services, because they're going to have to do those reevaluations on eligibility every 6 months for our expansion population, plus deal with making sure that folks are actually working who have to work under the federal work requirements. I mean, what we're heading to is worse than what we're in right now. All of this that we're talking about today with the Medicaid cuts, this was all self-injury through this system. And it's really deeply concerning because up to now, we had not seen rate cuts. Like in the regular budget, we had not seen rate cuts in either of the proposals for the House or Senate budget that would become our 2-year biennial budget. And we were concerned about that because of HR 1, that they would preempt cuts, and they didn't. And now we're in a position where we have serious cuts. I will say that in speaking with the governor's team, the one thing I stressed to them around the aging and disabled population is a single person is receiving in their care plan multiple cuts. It's not as easy as just saying Cap DA, Cap C. If you are a person who has a heart condition and you're a Medicaid recipient, your cardiologist got a 10% cut, right? Your PT and OT took a 3% cut. If you have durable medical equipment, that was a 3% cut. If you're using NEMT in order to get to your doctor's appointments, that was a 3% cut, right? So, and if you're using PCS, that's an 8% cut. If you're using PDN, and so I listed all of the cuts for them around one single person. And for those of you who know me, I'm really open about my disability and my multiple team of doctors that surround me on a daily basis. I literally use my medical record to show them how many cuts, if I had been a Medicaid recipient, my care plan would have taken. And I'm not sure, I think that was a disconnect, Mary Bethel. I think, I'm not sure they understood how that all went together.
Yeah, it's complicated. And you've got the General Assembly pointing fingers at the governor. You've got the House and Senate pointing the fingers at each other. So, it's a lot of politics and other types of things at play here too. So, but thank you, and Lee particularly for all you did and the Home Care Association to organize the Day of Action this week. I heard there were 250 people. and I believe it because I was there, 250 people at the opening session, and there were 500 walking the halls of the General Assembly. Now, of course, it was probably not the best day that you were there because that was the same day they were doing the voting on the redistricting too. So there was a lot of activity over on Jones Street if anybody was there that
But I
day.
have to say, big hats off to Lee and all of the coalition that helped us pull this off. We only had 5 days to plan this, and we turned out
Yeah,
500 people into the building. And we actually built an amazing relationship with folks that we normally don't all work together. We had the addiction professionals in North Carolina send people. Karen at Benchmarks. Y'all know Karen McLeod at Benchmarks. The North Carolina Provider Council jumped in. My clients who are IDD and Carve Mark and CIAPSI, they send people. We had folks from Lifespan Trust bus in 4 busloads of people into that building. We had RHA bring in 3 busloads of folks to that building. We had Southlight that does addiction recovery and support. They had 12 people in that building. You know, those are folks that we normally don't, you know, all work together on the same day at the same place. I mean, we have a lot of common interests, but one thing I strongly recommend is that we have built something that really worked, and we built it quickly. And I think it would be really great to hold it together because, you know, y'all know I'm going to say this because I'm going to say it. People with disabilities are living longer than ever before, and we're happy about that. People with intellectual and developmental disabilities are living longer than ever before. We're happy about that too. But there's going to be a natural intersection more and more between Coalition and Aging and all of these other associations. So anything we can do to work together to hold this together as we go in, especially with HR1, would be great.
Yeah, exactly. Well, thank you, and thank you for all you do, Julia. I mean, you're a great advocate for
Thank you.
many programs and services. You're right. There were 25 different organizations that had their logos on all the materials that were available for the Day of Action, including the Coalition on Aging. But there were also a lot of organizations that were very engaged that didn't have their logos on there, that chose not to put them on there. So, does anybody have any questions relative to anything going on? There's been lots of great news coverage. North Carolina Health News, North Carolina Newsline, PBS, UNC have done great news coverage about, you know, what went on this week and about the need for action in this area. I don't see any hands up on that, but this is, just know this is something that's going to continue to be on the radar for groups, and that along with the federal efforts that we'll be dealing with also. Yeah, we had a part of the agenda about federal and state development, so you've just heard a lot about the state developments. And as far as the federal developments, you know, we're continuing to see what's going to happen with the shutdown. We know that right now, most of the funding regarding aging and a lot of the service delivery type things is coming in. Julia mentioned some of the cuts that we're seeing already, though, with like, and some of the cutbacks. I mean, there are things like telehealth and things like that that are facing challenges. But if the shutdown goes, you know, past November 1st, there could be great implications about whether or not there's going to be money available for continuation of services and programs. So we'll see what happens. It's a very uncertain times. Gina, I see your hand up again.
Yeah, sorry. So not only telehealth, you know, I think a lot of people are continuing to provide telehealth, assuming they'll get paid back. But a more expensive thing is hospital at home, which is not happening everywhere, but it is something else that's not being funded right now. Does anybody have any practical knowledge of what's happening with hospital at home? Are we putting people in hospitals now? Are we discharging them? I mean, does anybody know what's happening? Because that, to me, is just a huge story. If you can keep them in the home, especially if they have, you know, some sort of memory disorder, otherwise we're sticking them in, you know, in a more expensive places of care. I mean, it makes absolutely no sense. But does anybody know anything about that?
I just know that the federal reimbursement, you know, certainly is an issue. I've some of the stuff I've been reading, it sounds like some hospitals are kind of continuing the program and looking at other ways they can fund it. So I don't know, but it's, I mean, it is a big issue, and I know it's used right much in the Triangle here, and I think in other parts of the state also. But between that and the lack of telehealth, it's going to be, it's going to have an impact because it's
Yeah.
certainly important part of the service delivery process that we're engaged in. I don't know if anybody else has any more insight on that or not. Okay. Just one other thing, we do have a newsletter either going out this afternoon or the first of the week, kind of summarizing a lot of what we've talked about today. Also, some interesting things on there regarding something we found out about, and y'all may have people you work with that have been impacted by this. Social Security is now moving to basically having people validate their ID before they'll give out information or make any changes that people are requesting. And that is causing some problems with a lot of folks relative to the fact they may not have an email address that they can do this with. Social Security has also gone to new providers to validate IDs. And if you enrolled in mymedicare.gov or mysocialsecurity.gov or whatever before a certain date, then you've got to re-enroll again. I know I saw some people from SHIP on here. I don't know if you guys want to say anything about that or not. Kevin, I don't know if you want to mention it, or Melinda or anybody that's on.
Hey, Mary, can you hear me?
Yep.
Yes, Mary, for what we know right now is anyone new that we are setting up a Medicare.gov account, they are required to have an email address, as Medicare.gov will now require a multi-factor authentication for an individual. So for SHIP, if we are assisting those and we're trying to set an individual up, well, we would ask them first if they have an email address to use. As we mostly know, the new folks that are coming into Medicare age, they more likely have an email address, but it's going to be those who have never come to SHIP before, that have never compared their plans or anything, that will be, it may be a little tougher to assist them. So with SHIP, what we will have to do is we may have to do a general comparison of their Medicare plans, and then we may have to have them to call 1-800-Medicare to enroll into a plan if they don't have the ability to create a Medicare.gov account.
Yeah. Well, and we've got an article about that in the newsletter, as well as just some other things that impact Social Security. Did get an email from one of our folks from Social Security who's usually on this call, saying that they basically, because of everything going on, he is now doing claims processing with Social Security instead of doing the types of things that he has been doing. So I think it's kind of an all hands on deck with Social Security staff to try to cover all the bases there. Let's see. Anybody else have anything for the good of the cause about legislation, federal updates, anything going on at the state level, or any questions you have relative to anything before we move on? I don't see any hands. Okay. All righty. So Health Equity Committee, I know that Daryl is at a family wedding right now and not here, and I believe Rosalie had a conflict, but I think Mary Williams Stover, I believe you were going to talk and just tell folks when the next Health Equity Committee meeting is.
Mary, I was just typing in the chat the update about the upcoming Health Equity Committee. So yes, Dr. Davis Fulmer is the chair, and she asked me to just remind folks who are on the call that the North Carolina Coalition on Aging does have a very active health equity work group, and that we do convene a meeting every other month for the full work group, and we're still looking and open for people who want to join us. And that next meeting is going to be November 14th at 10 o'clock a.m. We meet for an hour. If you have not joined us, please do watch for an announcement with regard to the speaker. We will be following up on an excellent presentation that Divya Cupid did last month with regard to all ages, all stages, and the impact of that work on health equity, which is not an add-on. I love what she said, but you will receive an invitation and a notice from Sandra. So just look for that. We are still looking for a speaker for that session. So stay tuned. And if you don't know about our group, you can check out the details on the website. We have 4 committees, and we're focused on tobacco cessation and dementia and Alzheimer's. Also looking at workforce barriers and LGBTQ inclusion and health disparities with regard to rural communities in rural North Carolina. So very robust group, comprehensive and important work for the coalition. Open to any questions.
And just as a reminder, we have 3 subgroups under the Health Equity Committee. We've got BIPOC, we've got LGBTQ+, and rural.
Yeah.
Mary, I don't see any hands up, so thank you very much for that announcement. And you guys, hope you'll be interested in joining that committee when they have their next meeting on November 14th. All righty, very good. Thank you much. All righty. Well, I see our speakers here, so right on time, and we're at the point of the agenda where we can just go right to you. So welcome, Dr. Larry or Lawrence Greenblatt. He is the State Health Director and Chief Medical Officer for the Department of Health and Human Services. It's good to see you. Thank you so much for joining us. I've been in a couple of meetings lately, and people kept talking about Dr. Larry, and I didn't know who Dr. Larry was because I'd always heard your full name, but evidently you go by Dr. Larry. So we're glad that you're here. And just to give you a little bit, like I say, we sent out his bio ahead of time, but he's a physician, he's a professor, he's a public health champion. He has done a whole lot of work about integrated behavioral health and addiction services into primary care. He came from Duke Medical Network, the Duke University Health Center. He's done a lot of clinical work there. He basically has looked at the whole addiction issue, behavioral health, what can be done, treatment options for opioid use, and I mean just the whole Medicaid field too. I mean, he's been a leader in North Carolina. He's chair of the North Carolina Medicaid Pharmacy and Therapeutics Committee, or he served as chair, and he was secretary of the North Carolina Medicaid Physicians Advisory Group. But Dr. Greenblatt, I'm going to let you just tell anything else about yourself that you want this group to know, but know that from what I'm reading your bio, your hands are in a lot of pots right now, and you obviously have the background to stir all those pots and to be very actively engaged in things. We are really excited you accepted the job as the State Health Director and the Chief Medical Officer for Department of Health and Human Services, and that you're with us today. So we'll turn it over to you. And you're on mute.
Yeah, thank you. I think it's only the folks in the Division on Aging at DHHS who like to call me Dr. Larry. They all say Dr. Larry. But you can call me whatever you want. I do go by Larry. I don't go by Lawrence. And another thing I was going to add, thank you for the very warm introduction. At Duke, I joined in 1994 as a primary care internal medicine doctor. And my practice filled quickly, as tends to happen with primary care, and I closed my panel, I think in 95. And then I was there like another 29 years, or really almost, no, a little more than 30 years. And your patients just hold on tight, So what happened was, as I got older, my patients got older, and I essentially became a de facto geriatric specialist because all day long I was seeing people 75 to 95, and my younger people had moved away or whatever, but the older people say, you're going to be my doctor until I'm dead, aren't you? That sort of thing. And that proved to be often the case, and a lot of loyalty. So I really enjoyed being a doctor for people as they kind of aged into, a different phase of life, different challenges for sure. And I would say my patients, we communicated a lot about aging and about planning for the future, those sorts of things. And anyway, it's a pleasure to be here today. I'm going to give kind of a broad overview of some of the things I do at DHHS. And really it is some, because I have my hands in many, many other things. And these are things I think would be maybe of interest to this group. And I think I'll have time at the end to take questions. Normally I present off of 2 screens and all that. We're actually having a retreat today, which I stepped away from. So I'm only 1 screen. I'm a little more limited. So give me a minute to just get the slides showing. I'll do that right now. Okay.
We appreciate you being here, knowing your schedule was already full.
Oh, that's fine. No, I'm happy to do it. Actually, you invited me before we planned our retreat, so you guys took priority. And my secretary, Dr. Sangvai, he understood. He was fine with my doing this. Okay, so are you seeing now a full screen of my slide?
Yes, we are
You are.
now.
Perfect.
Yep.
Okay, very good. So this is just an overview of what does DHS do? DHHS do. DHHS is a very complicated organization. We are, I think, one of the biggest, if not the biggest, state agency, and we have 18,000 employees. 33 divisions. Each division is kind of its own entity and has its own structure and things that they do. And I just want to kind of introduce you a little bit to some of the efforts here. So I'm going to start at the top. Health. So that's there's all kinds of initiatives around like promoting vaccines, healthy living, falls prevention, healthy aging. There is just a range of things that happen under health, and you'll see if there's an outbreak, if there's a contamination, DHHS is on it. We're in the public eye. We're applying science where possible to improve health. Human services includes things like the WIC benefit, which gives food assistance and formula assistance to women's infants and children. You've probably been hearing in the news lately the SNAP benefit, which is a partnership between state and federal government, is under threat because of basically we're running out of the federal dollars. So we have 1.4 million people who receive a SNAP benefit. About $200 per person is kind of typical. And that's going to be devastating to those individuals and those families where that's the majority of their food budget, what they get under SNAP. And we have lots of other human services. That's foster care, that's child welfare. It's many, many different things within human services. The Medicaid program is the most expensive program that DHHS runs. It's a $34 billion program. We have more than 3 million North Carolinians who are covered under the Medicaid program. The biggest expense overall is the payment that goes to seniors who have both Medicaid and Medicare who require a facility. So those are people that are long-term in a skilled nursing facility and the like, and often Medicaid is what's paying for the long-term treatment there. Medicare pays for short-term rehab after hospitalization or an acute illness and the like. But that's a big part of what we do. We certainly focus on operational excellence. That's why we're having our retreat today, coming up with our strategic vision. What do we need to improve? How are we going to do it? Great ideas. The people that I work with at DHHS are just a joy. They are absolutely committed to what they do, really capable people. That's been, probably my favorite part about my new career trajectory here. DHHS runs 13 facilities. Those are hospitals for mental health. They're programs for people with intellectual developmental disability. They're for children. They're all around the state. And that's where the majority of our employees are in these facilities. They are very often cutting edge and are providing safety net care to the most complex and vulnerable people in the state. And often they're doing it in a way that, when we're getting ready to discharge somebody from there isn't someone who can provide care at the level. So if you have maybe a stereotype of a state hospital being kind of like not as good or whatever, actually they're the best. And they're also, a number of them are really quite nice facilities too. They're not like run down like maybe you've seen in a movie or whatever. We also license other existing facilities that we have to oversee, make sure they meet quality, et cetera. So that's another part of the DHHS. There's much, much more. We could spend an hour just on the structure of this organization. Okay, now I got to figure out how do I move my slides. There it is. Okay, so I'm gonna start with a program that I got involved with early, Cannabis Council, and I'm gonna try to make a case that this is relevant to people who are interested in aging. The week before I started, I got an email from the governor's office. The governor has selected you to serve on the Cannabis Council. I thought, oh, that's interesting. What do I know about cannabis? Soon to be a lot. The next day I got an email that said, the governor has chosen you to lead the Cannabis Council. So that's a whole different level. And I'm actually the co-chair. My co-chair is Matt Scott, who is a DA in Robeson County. I mean, honestly, because I work at DHHS and my time allows, I'm kind of more involved than he is, although he's a great partner in this. I'm going to just make a few comments about cannabis and also focus on seniors. So cannabis use going up quite a bit. These are the kinds of numbers that people report when you survey them. These may be underreports, but you can see even in middle-aged adults, you know, it's pretty common. Daily 8% for middle-aged adults, 19% said they used at least once in the last month, and overall these numbers are up. And I'll show you they are going up. So that graph you see on the left, the green and line with the yellow dots, that's daily or near daily use of THC products. THC is basically the active ingredient in marijuana or cannabis. That's what gives people the high. And there's been a 20-fold increase since 1990 to what we see today. And this doesn't even include like the further increases that we've seen since 2020. The red line there is alcohol, and daily or near daily alcohol use is increasing as well. And there was a substantial rise that has persisted with COVID. A lot of people stuck at home were drinking more and apparently using more marijuana. The graph on the right is about daily use, and this is more current. It goes up to 2023, and it only goes back as far as 2013. So it's kind of part of what's on the left. And you can see for both young adults and middle-aged adults, there's been steady rises. It says Colorado legalizing marijuana, but really this data on the right is a national sample. It's not one state only. This is something that a lot of people are not aware of, is that the potency, or really the dose, how much THC is in cannabis products. And this is really specifically for the plant itself. Like people smoke the flower, which is a part of the plant. And it has increased dramatically. And going back when a lot of us who are on this call today were young, it was much lower even than what you see in 95, probably half as much. So we're seeing this roughly 10-fold increase in how much THC is in what people are using. And that has a lot more health adverse effects. More people become addicted to cannabis. More people develop mental health disorders like depression and anxiety. And there is, particularly in young people, a steep increase in the risk for developing a psychotic disorder, where somebody is like hearing voices, seeing things that aren't there, probably an increased risk of full-blown schizophrenia, which is kind of a permanent condition. There's something about the developing brain that's particularly vulnerable. There's also more adverse effects in people who are pregnant when they use more with their babies. So we're going to really need to work on that. So this is specifically in people 50 and older who reported using at least once when they were asked. This is a poll from one state, from Michigan. However, it was a national sample. So the University of Michigan researchers sampled across the country. And if you look at these reasons, 3 of them really are medical indications. And that's typically true for older adults. They're not necessarily looking to just get high, though some are, but they might use it because they're having trouble sleeping, a common problem for seniors. Pain relief, another common thing. Many older adults live with pain, or to help with their mood. It's probably not very good for any of those things, really, at least not beyond the short term. And so it's not a great use, but when people use, that's often what they're looking for. And what's available in vape shops, and we have a lot of THC being sold legally in the state in vape shops, the doses tend to be much, much higher than what people need for medical indications. If you're 60 or 70 and you want help with sleep, you might want really a 2 milligram dose or a 1 milligram dose. And what you might see in an edible that you buy over the counter might be a 10 to 50 milligrams in one dose. It's a huge amount, and that's problematic. And I'll show you some data on emergency department use among seniors. It's really skyrocketing. So that's here. This is now specific to California. This was published in the Journal of the American Geriatric Society. And this just shows you from 2005 to 2019, the numbers of people needing to go to the ED for an emergency related to cannabis use. And it's just gone through the roof. And again, a lot of this is people trying to treat a medical indication, probably taking a lot more than they should, particularly when they're first starting out, don't have any tolerance. And then they feel, acutely ill from it. They can feel anxious. They can get rapid heartbeat. They can even start to like have psychosis with a dose or two. And this isn't the long-term effects. These are the short-term effects that drive people to seek emergency care. So in June, the governor issued an executive order creating the Cannabis Advisory Council. This is the one that I referenced early. And these were some of the things that the governor was trying to achieve with that. He was very specific. He did a TV interview, which I think you can find on YouTube. It was on WRAL, talking about why are we doing this? And it really came down to, if you look at what's available for sale in vape shops, there is all kinds of cannabis products. Well, we are not a cannabis legal state. How could this be? And the reason is because of federal legislation in 2018, which gets referred to as the Farm Bill. So the Farm Bill was to try to support farmers who wanted to grow hemp products. And the goal was so they could grow it for use in fabrics or rope or things like that. And the hemp, the law defined, by the way, marijuana and hemp are the same plant, different strains of THC. So the law said if the cannabis, if the product had a concentration of 0.3% or less, it would be considered hemp. Above 0.3, it's marijuana. And that was really based on, like, if you had some like leafy dried powder, like that's like essentially what people smoke, if that's more than 0.3, then that's going to be considered cannabis. So people figured out, well, gee, you could make like a drink, and as long as less than 0.3% by weight was THC, then it's okay. Now, a drink could weigh 300 grams. So 0.3% of that is going to be like 900 milligrams of THC. That's a lot. And as opposed to like if you had some in your handful that somebody was going to roll into a joint or whatever, that weighs so little. So if you go to a vape shop, the edibles and the drinks and things like that, they should all be under 0.3%, but that still can be an amount to intoxicate, like one package could be enough to intoxicate everybody on this call. It's really a remarkable amount. Also, we don't have any age restriction because we don't have legal cannabis. So a 15-year-old can take money they earn babysitting and go in and buy cannabis products, THC products, technically derived from hemp, and technically under 0.3, but believe me, way more than enough to get intoxicated and enough to cause problems. So protecting the youth is a big part of this. There also needs to be public health, education. Don't use before driving or operating machinery. Don't use if you're pregnant. Many, many rules around this. So these are some of the things that they wanted from the Cannabis Advisory Council. Surveillance, we have systems in place that look at ED visits. There's other things that we could be monitoring. We don't test the products that are for sale in vape shops. They can have contaminants in them like pesticides or chemicals, heavy metals and the like. In states that have legal cannabis, all the product needs to be tested. We're not testing. We don't verify if it says it has so many milligrams per dose. We don't know because nobody tests the product. In a state where it's legal, you can have a lab, paid for by the taxes on the products, that is testing and making sure that it's okay. Also, you can have licensing. We don't have licensing. Anybody can open a vape shop, but if it becomes legal, then we can actually truly regulate, and that's what the governor is hoping for with the Cannabis Advisory Council. He hopes to advance justice. There has been, under this kind of making all THC products illegal in the past, there was unequal enforcement of those laws. Similar use of cannabis products amongst white and then black and brown communities. However, like 3 to 4-fold increase in arrests and legal problems for people who are in the minority communities. And what he would want to do would be to say, okay, anybody with a past conviction, when it was illegal, we're just going to take that off the record so they can get a job, so they can get a loan, so they can, go to school, these sorts of things. It hurts people long-term when they have a felony conviction around drugs. I mentioned taxation, sales restrictions, licensing, all that. That would be part of it. Now, the council's role is to create policy. We then would hand that off to the General Assembly, who can turn it into law if they wish. So we have to make a set of recommendations that are ones that are feasible politically to pass. So this is just the timeline. We're meeting every other month. We have to have our preliminary stuff in by mid-March, our final recommendations by the end of December. This is in 26. So who's on the Cannabis Advisory Council? It is a diverse group. It is challenging to kind of get everybody's thoughts and ideas and perspectives involved. And we want it to be very much a group that works together and thinks about things as a group and not, our leadership just deciding what we do. So we have 27 members, 4 in the General Assembly, 2 senators, 2 representatives. We have me and my other co-chair. We get lots of support from people that work in government, both on the governor's side and in the DHHS. Everything we do is public record. So if you wanted to watch a meeting, it's going to be streamed on YouTube. There's minutes that are published. All of our materials are shared, like slide decks and the like. We don't operate in any way secret. It's all open. People are welcome to submit their thoughts and ideas. And do they think what we're doing makes sense? Would they recommend, no cannabis in the state, shut down the vape shops, get rid of the whole thing? We've had nearly 3,000 comments on the website. So we are planning to go through all of them, but that is a way for the public to be involved and can show up at the meeting so they can't participate. We are dividing our group into subcommittees, 3 subcommittees at a time, to work on specific issues so they can dive deeper, bring in speakers, look at what other states are doing and the like, and then they'll report back to the larger council. And then once we're done with the first set of issues, we have another 3 to go. So we have 6 total subtopics for these subcommittees, and we have leadership on the subcommittees who won't be the overall chairs. We will vote on things. We don't have to have unanimity, just majority rule is what we're going to do. And then we will turn it over to the General Assembly. And hopefully, because we've had involvement with these 4 members, 2 of them have very strong opinions about cannabis. They will be able to be the leaders in trying to get a bill passed. There have been multiple cannabis bills that have gone in front of the General Assembly. None have passed before. And that's why we still have no age restrictions, essentially no rules. I'm going to switch topics here and talk about the Rural Health Transformation Program. This is a federal program. You might have heard at the time that HR 1 passed. That's what some people will call the big, bold, beautiful bill. That took about $50 billion out of North Carolina's Medicaid budget, $1 trillion out of the country's Medicaid budget over 10 years. And some people in Congress complained that this was really going to adversely impact rural health. And so very quickly they put together, well, let's put some money towards modernizing, improving the care in rural areas, which face all kinds of challenges. And that's really true in all of our states. It's particularly true in North Carolina. So that's $50 billion. And that is going to be distributed, and I'll show you in what way. And many people don't know, and I honestly had no idea, we have the 2nd biggest rural population in the country. Texas has the most rural residents. We have the 2nd most. Some states have a higher percentage that are rural. Like, for example, 60% of people in Vermont, a little more than that, live in rural communities. But Vermont's total population isn't very big. For us, it's about 30-35%, depends on how you define rural. But that's of 11 million. So we have about 3.5 million rural residents. And again, Texas #1, we're #2. So the CMS sent out this notice of funding opportunity in mid-September. We knew it was coming, with like, this is what we're looking for in your application. This is what we want you to try to achieve. They said this isn't to just give money back to the providers and the hospitals who aren't going to see those Medicaid dollars because of a reduction in Medicaid benefits or a winnowing down of the numbers of people on Medicaid, but really they want you to use it to invest in those communities, change the way care is delivered, modernize it, improve it, to try to improve health care delivery, but also just to improve health. That might be nutrition, it might be helping people quit smoking, figure out ways to be more physically active, things like that. So these are some of the big issues that really affect rural communities. Access. So there are not nearly enough primary care providers, about half as many per, say, 1,000 people relative to our urban areas, about half as many. When you look at specialty care, it's 1/10. It's really hard to find specialty care in rural communities. Dermatology, cardiology, cancer care, you name it, it's all in really short supply. So people have to travel long distances and it's hard to get those appointments. And sometimes people who live in rural communities have less money, less resources. So even just paying for the gas to drive 75 miles to go see their cancer specialist, you know, who they might have to see on a monthly basis, is really burdensome. People that live in rural communities have a higher burden of chronic disease, things like hypertension, diabetes, asthma, heart disease. All of these things you see at a higher rate, like 20 to 50% higher, depends on the condition, but it's a lot more. Lower incomes, poverty rates are definitely higher in our rural communities, and there's more, like substantially more senior citizens. They tend to have more chronic disease. That's part of getting older. You may know that if you're, you know, a senior yourself. And all of these things together are just enormous challenges for, you know, health in rural settings. So this is how the funding's going to go. There's $50 billion, which will be distributed over 5 years. So it's basically $10 billion a year. They took the first half of the $10 billion and said, we're just going to split that evenly among all the states, which might sound kind of like equal and even. I'm going to tell you, in my opinion, that's not very equal. We have so many more rural residents than other states. So we have like 35 times as many rural residents as Rhode Island. They're going to get that same 100 million that North Carolina is going to get. So they did that. So I don't particularly love that, but okay. They didn't ask me. The second half, so another $5 billion every year, will be divided according to the strength of the application, which includes things like how many rural residents, what partnerships and infrastructure do you have in place, what innovative ideas are you proposing? There's a whole series of these things. North Carolina is well set for that. We have an Office of Rural Health. We are the first in the country that has that. It's very proactive, lots of partnerships, lots of working with hospitals, community organizations, primary care clinics, federally qualified health centers, nonprofits, but just all kinds of work that's already there, a lot of innovative thinking. So we can invest in existing programs. And then also there's a lot of things that people have thought about that they just needed the money to really implement them. And honestly, we've brought together a terrific team that's been working on what kinds of things do we want to propose here. And that's been an area of intense work in the last few weeks. These are some of the things that we are specifically wanting to work on: improving access. So some of that's going to be, for example, by encouraging more providers to work in rural communities. Some of that's going to be by enticing them with money, but also making for better work environments. We're also going to implement a lot of telehealth where, if you need to see, let's imagine a cardiologist, maybe we can find cardiologists who could do that visit through video. They don't necessarily want to drive all the way out to the rural area. The people in rural areas don't want to drive to the urban centers, but often the care can be provided effectively, at least some of the time, through technology. And that's already happening in some places. We're going to really try to expand on that. We're going to help train people how to use these technologies. Older adults in rural settings may not be very comfortable with, internet and a Zoom meeting and the like, and try to make those matches work. We're going to try to strengthen the workforce. That's not just doctors, that's nurses, that's direct care providers, that's physical therapists, pharmacists, pharmacy technicians. There's a whole range of areas that we really need to bolster that. There are other state efforts that have already been working on those things. Partnerships between providers, between hospitals and clinics, all kinds of different relationships. We're going to have 6 or so areas where we have a hub, and they're going to try to coordinate some of these efforts with a lot of support from DHHS. And really, we're going to be measuring outcomes and looking to improve those outcomes. Is diabetes control improving? Are people in the hospital less? Are mortality rates going down? Are women who are pregnant having healthier babies, avoiding preterm deliveries or the complications of pregnancy that we often see because the access to prenatal care is so limited in so many of the counties? So these are this is our vision for North Carolina. So you heard improved health outcomes. This is across the lifespan. It's mental health outcomes and physical health outcomes. We want to see drug overdose rates go down, suicide rates go down, a reduction in hospitalization. better access to all kinds of services. We wanted to bring it to people through mobile delivery models. That's going to be like sending vans and trucks out. It's going to be trying to create programs in communities, maybe in non-traditional settings, support the workforce so that people don't feel the need to move to somewhere else. There's a lot of older providers in rural communities, trying to keep them working so they don't want to retire. Integrate the systems of care, much more sharing of data. There's a network called the Health Information Exchange. The brand of that is Health Connects, and trying to allow individual practices and hospitals to have information from other hospitals, other practices, so that if a person was hospitalized or had a series of tests or whatever, all that information is shared with anybody who's involved with their care. And that might be at a home health organization, it might be their primary, it might be their specialty doctor, and there's a lot of investment in making that work. We want this all to be sustainable. That's a key word. The government funding is 5 years at a pretty decent level, and then it goes to zero. That's it. It's no tapering off. So we have to figure out, how do we implement changes that can continue after we are no longer receiving those federal dollars. So a lot of thought going into that. And then obviously access is a key thing. We are trying to recruit the workforce from rural areas where possible. Encouraging high school students, think about a career in healthcare, think about getting your associates so you can become a pharmacy technician or go to nursing school, go to medical school. These are the healthcare providers are very disproportionately coming from urban settings, and they generally want to return to urban settings and not work in rural areas. We're going to create rural residencies and fellowships and training for other kinds of healthcare providers in these places so they can learn about them and learn what it takes to be successful there, and hopefully learn to love the communities and the kind of work they'll be doing. So these are some of the dates we have. Our application is due in November 5th. We're aiming for November 3rd. The application is, I'd say, mostly done. We have a consultant working with us on it. It looks really strong to me, very well thought out. We will find out at the end of December how much money we'll get, and that amount can be anywhere from zero to hundreds of millions on the second half. I'd like to think we're going to get more than average given the size of our state rural population and the strength of our application. So we might get as much as $250 or $300 million a year for 5 years. We don't know. The cuts were much greater than that, but that would certainly help a lot. We have a website if you want to look at it. There's been a press release about this. So that's all I want to say on that. I want to cover a couple other things before we run out of time. So veteran care, this is an area of interest for DHHS. We are partnering with the North Carolina Institute of Medicine on this. We have a large veteran population. These are people who have served their country. They have unique health needs and sometimes mental health and substance abuse needs, and they often have worse health outcomes, particularly when they first leave the service. That's a really tough time to transition back into civilian life. And we want to know that our veterans, there's a commitment to them, that they can access the services they need, within the Veterans Affairs system, but also in community settings. We want community providers to be more skilled and knowledgeable about caring for veterans. There's a lot to it. So these are just some of the initiatives. The Ask Me NC campaign. This is about asking people, did you serve in the military? And then if a person says yes, they might be eligible for programs. They might have different issues. There's a lot of PTSD from people who are combat veterans and the like, or people who are unfortunately victimized in sexual trauma, which is an all too common event in the military for female military service providers. The 988 line, that's available to anybody, but there is a direct connection for veteran services where somebody who's more specialized in that can counsel them. And then this partnership, which I participate in personally with the North Carolina Institute of Medicine, trying to really create a comprehensive set of services for veterans. We have the most comprehensive program in the country right now. And I can't say we've been the best traditionally, but we want to be the best, and we're aiming for that. Some workforce challenges, you heard me mention a few of these. We've had a lot of rural hospitals closed since 2006. And when we say converted to rural hospital status, that basically means they have an emergency department and they can do brief inpatient like hospitalizations, like kind of what we call observation, not true full-on hospital care. We have workforce shortages that are acute throughout many of our areas. I'm going to show you some maps. Maternal care, some counties it's not enough, some counties it's literally non-existent. People who are pregnant have to leave the county to get their prenatal care, and definitely have to leave the county, sometimes long distances, to deliver. And if a person goes into early labor, it's then an emergency. Ambulance, sirens going, and they're trying to whisk that person to a place where they can safely get labor and delivery care. So I'm going to show you some maps about these health professions shortages. So this is for primary care. We have 93 counties that are low in primary care. So just a handful really where it's sufficient. Orange, Durham, no surprise. But overall, it's pretty darn low. Mental health care. Some counties have really essentially no mental health care and no addiction care. But many of them have at least some part of the county where it's insufficient. So 97 of our 100 counties don't have enough mental health care. And that's not just doctors, that's nurses, that's direct care providers. There's a whole range of people that help provide mental health care, just like physical health care. So these are some of the programs that DHHS is involved in. This is one in partnership with the UNC School of Social Work, trying to make more robust the social work workforce, and to also encourage them to work in our rural communities where they're really short social workers and the skills that they bring. So some of this is public awareness of like, what are the careers that one can do in social work, which are diverse and often quite satisfying. We want to train them to be more effective in rural areas where the issues are different. The social services that are available often are quite different from rural areas, and one needs to know different things to be successful there. And then trying to create resiliency so people can stay in social work. It can be a very stressful job, and people do get kind of burnt out and sometimes move into other career paths. Direct support professionals, these are people that do the hands-on care. You can imagine if you were visiting a nursing home, you might see people who come and do the bath or clean somebody, or help them in and out of bed and the like. We have direct support professionals that work in physical health. They work in our facilities. They work in our hospitals. They do a whole range of things. If you were to ask the people who run our psychiatric hospitals, where's your biggest shortage area? They would say the psychiatry techs who work directly with the patients with therapy and helping them with recreational activities, or reminding them to do the things that they need to do. We are very, very short these direct support professionals. These are jobs that are hard. They don't pay particularly well, and we don't have a great way of recognizing career advancement or promotion. And we're trying to create those kinds of systems so somebody could do this work and over time make more money, be promoted, be recognized for their skill set. So we're trying to recruit more and trying to support them. Trying to recruit more people into the mental health space. The General Assembly approved a $20 million loan repayment program for people who work in underserved communities, which you saw 97 of our counties have some areas that are underserved, some it's the whole county. And that really allows people to take jobs that maybe don't pay quite as well too. Nurses, same idea, loan forgiveness. It's a way to get people to work in the rural communities. Again, the payments might be lower. We need a lot more nurses. They have to commit to 4 years. They can't just come in for 6 months, take the loan repayment and say, see you later. It's a commitment. There are similar programs for doctors. Some are state funded. Much of that is federally funded. This is the workforce working on the overall state issue. We come up with lots of good ideas there, lots of innovation. I was at this meeting. You can't recognize me there, but I'm in this picture. And some really great ideas about training and placement and encouraging people to do this work. We don't have enough people to teach them either. So we need to create the teachers and then create the workforce. Okay, we're working with community colleges and the UNC system. This is around creating more, like taking clinical nurses and training them how to be nursing instructors, because we don't have anywhere near enough nursing instructors. It's 45 hours of training, and they get a lot of help to be more effective at teaching nursing students. Okay, I think I mentioned some of these. Okay, the last piece I want to touch on is peer support professionals. These are individuals who have lived experience with either mental health or substance abuse issues themselves. These are people who are now in recovery, doing better, and they are often our most effective means of reaching out to people who need these services, talking them through the process. How do you get care? Why do you want care? What's it like when you're no longer using drugs or no longer drinking, or when your mental health condition is treated effectively? And often they are great at building trust and building those relationships and helping getting people plugged into needed services. And UNC is helping to standardize the training and essentially certify people as peer support professionals, which can be a career path for people who maybe didn't go to college, who want to do some work and help people that are going through issues that they have already kind of gotten past. Vaccine guidance, you might know there was a standing order for COVID. That came out because the ACIP had some delays in getting their recommendations forward. So there was lots of concerns. We got literally hundreds of letters and notifications. The governor's office got hundreds saying, why can't I get a COVID vaccine? So we put that forward. The DHHS very pro-vaccine. In the slide, it says October might be the best time to get vaccinated. I would say if you're over 65, probably November is better because flu really arrives typically in early to mid-December. Older people have a shorter duration of immunity with a flu shot, and flu season can go through March or April. And if you get it too early, like don't get it in September, your protection may actually have gone away and flu can still be circulating. So this just mentions the standing order. I think we had about 95,000 actually who got the state standing order issued vaccine. It had my name on it. That was kind of a nice thing. I got lots of kudos. It was a team of us who put that standing order together. My name got put on there, but it was lots of people working on it, and really the lawyers who figured out how to issue it given working within our state statutes. So now pretty much anybody who is 6 months or older can get a COVID vaccine. You have to be above 3 to get it at a pharmacy. A pharmacist can't give a vaccine to a young child. This is a new thing which you might not have heard about, influenza testing and treatment and prevention. This just went in this month. This is a new standing order. An individual who has flu symptoms can go to a pharmacy and be tested for flu. And if they are a high-risk individual and test positive, they can be treated right there. No doctor, you don't have to go to urgent care, and they can just essentially dispense the medication to them immediately. Pharmacists are being trained in how to do this, how to recognize the signs and symptoms, how to do the testing. They also can do preventive treatment. If you're a high-risk individual and you've had a close exposure, imagine you're 75 and like maybe a friend came over with a little cough and fever or whatever. They told you later, oh, listen, I tested positive for the flu. You could then go to a pharmacist who could evaluate you. If you're not showing signs or symptoms, you can take preventive medicine, which is highly effective in reducing the risk for flu. And flu is quite a contagious thing. So it's all of those things, testing, treatment, and prevention. And that is now available. The insurance piece, it has not really been worked out. Insurance companies are working that rapidly. Right now, if you went and did it, you'd have to pay. I think the fees will be not too high. Pharmacists are sensitive to that. So that's all I was going to say today. I realized a lot of content. Hopefully that was relevant to the kind of things that you might be interested as a person interested in aging. I'm going to stop sharing. Thank you for your kind attention. Do we have time for questions, or am I
No, we've got time. We're
Okay.
good. My goodness, there's a lot going on.
Yeah, that's a part of it.
You're meeting yourself going and coming, it sounds like, for sure. So I'll start with just one question. Well, we'll wait for people to raise their hands if they have questions. So just to clarify, with COVID now, anyone in North Carolina can get the COVID shot and insurance will cover it if they have it. Is that correct?
That's true. To get it at a pharmacy, you have to be high risk, meaning you're 65 or older, no specific high risk condition, or you're age 3 to 64, and you have at least one high risk condition. That list of high risk conditions is really broad, and it includes things like you're sedentary, or you have asthma, or you have heart disease, or you're overweight. I mean, it's quite broad. that is in line with the ACIP recommendations. However, a healthcare provider can order it for anybody. If a person says, listen, you know, I visit with my mother-in-law all the time and she's getting cancer care, I don't want to, you know, risk spreading it to her. You're much less likely to spread COVID if you've personally had a shot, but you couldn't get it from a pharmacy if you don't have a high risk condition, but your doctor could give it to you or your nurse practitioner or whatever. So it's pretty much wide open now, pretty much. Not as wide open as last year, but it's close. The majority of adults could get it at a pharmacy.
Gotcha. Very good. Thank you. Questions from anybody? Raise your hand if you do, and we'll try to get you.
This is Sandra. I don't so much have a question, just a thought. I'm glad I live in North Carolina. Thank you for the forward thinking of the rural areas, and just everything that the department does for health in North Carolina. My mother lives in a rural area in northeastern North Carolina, and it's an hour and a half to take her just to go see her cardiologist, who then sees them for 15 minutes, and then we drive an hour and a half back. So things like that really do make a difference. I'm, you know, fortunate she has someone to take her, but otherwise we'd have to look at other means. But yeah, I like all of the things about the forgiveness of loan debt and things for people who work in the rural areas. I think that's very important as well. So thank you for the work that you're doing, and please extend that to the folks that you're working with over there.
Great. Thank you, Sandra.
Thank you.
Gina, I see your hand.
Yeah, just shout out Dr. Greenblatt. He's a
Gina
rock
and I
star.
are mutual fans of each other.
Yay.
He's in
Everybody
many
knows
ways.
Gina.
Well, just what I want to say, you know, he also trained young providers at Duke. So it's a big loss to Duke in the sense that he trained generations of people to be as a rock star as he is. So we just want to give him a shout out for that. I could say lots more, but really
That
just
was an
appreciate-
unpaid comment. I did not.
Yeah, that's right. Just
That's
love
great.
your enthusiasm for this work. Love what you're hitting on. Love the plan for rural health. I mean, I agree with Sandra. We are lucky to be in North Carolina right now, for some reasons, not for other reasons, but for the reasons you shared. Absolutely. Just to clarify, and I'm sorry I had to get on a phone call briefly, but so the payment, I think Mary asked about the payment. So if I'm going to get a COVID shot, you know, you can maybe get it at the pharmacy, but who's paying for it? Like, how does that roll out? And I should know that, but, and then, yeah, that's the first, and then the testing, like, you know, you used to be able to order from the federal government testing for COVID, but North Carolina doing anything with testing kits and affordability there?
I don't think there's free test kits at this point and the like.
Yeah.
And I think if you go to a pharmacy, you may have to pay, you know,
Yeah.
on your own. Now, the immunizations, before we rolled out the state standing order, we very carefully, you know, we met with the provider community, but we definitely met with the insurance provider community, like all the payers, we call them the payers. And interestingly, they said, no problem, we are planning to pay for COVID vaccines. Medicaid paid for them right through. And we said, what if a person doesn't actually have a high risk condition, but they end up getting one? You know, are you going to pay for it, or are they going to somehow see that bill back to them? And they said, you know how hard it would be to figure out who had a high risk condition and who didn't? They said,
Okay.
we're just going to pay for them. And so
Great.
they are not putting that, it would be administratively and financially onerous for them to figure that out. So pretty much,
What about uninsured
can
people?
say-
What about uninsured people?
okay, then nobody's going to pay for theirs. So
Okay.
they might do best to get theirs, for example, from a health department
Yeah.
or from like a federally qualified health center where costs are
Right.
in other ways.
Right.
thank you.
Where Dr. Greenblatt's wife works, by the way, 'cause
Yeah,
she's
yeah,
also a rock star. So thank you
Yeah.
so much. Yeah, that's
She has worked for 31 years at a federally qualified health center. Roughly half of their patients are uninsured, and you know you pay, you know, according to a sliding scale, and you don't pay for each thing. You know, you pay $20 for your care, whether you got a COVID shot, a bunch of lab tests, whatever. It's all covered under that fee. So it does
and-
make care much more affordable, and we're
Right, and I'll
trying to
just-
bolster
I'll-
that. In
That's
rural
right. I'll just
areas.
add one more thing. In our local health department, senior pharmacist has picked up free COVID tests that we can give out to people. So if you're looking in your community to help some people with some of the testing, you may be able to get it at your health department as an agency or something, just FYI. Thanks so much for all your leadership. Keep it up.
Thank you.
And I noticed that Gina has put a comment in there about the role that your front porch played in distribution of masks and things like that. So,
125,000 masks we distributed.
all righty, that's great. And Teresa Troop had a question. She says, is the initiative for serving veterans in addition to services through the VA or for people who are not served through the VA?
Yeah, I would say in addition to the VA, and we certainly have people who are VA health providers or employees who are working with the Institute of Medicine and trying to think about it. The VA really is a kind of a specialized provider system for veterans, and honestly, they do a great job. But so many veterans receive their care outside of the VA system, and that's where things tend to fall down. So that's kind of what we're focusing on primarily. We're not like telling the VA how to do better with veterans, but we are kind of telling community, hospitals and health systems how to do better for veterans.
Right. Other questions from anyone? Well, I personally did not know about the new initiative about influenza tests, treat, and protection that's in place. So that's really huge. I mean, it's going to save a lot of people doctor visits and make it really accessible for folks to go to a local pharmacy to get that. But you're saying right now it's in the early stages, and people might need to wait a little bit to make sure insurance coverage and things like that.
That's correct. Flu season normally starts maybe December 5th through 15th or so. So hopefully by the time flu arrives, some of that will be in place. Yeah, and part of the goal, and thank you for pointing this out, is to decompress urgent cares, emergency rooms, primary care, who tend to be just swamped during cold and flu season with people who are ill and seeking care. And it's not only to make it easier for people, but also to make it so that people who have other conditions can access care. You don't have a 3-hour wait at the urgent care with a waiting room full of people battling the flu. Hopefully some of them can go to a local pharmacy instead.
Right. I do not see any more hands. Anybody else have one last question before let the doctor go back to his retreat? Okay, I don't see any. So
Yeah.
lots of hands clapping, things of that nature. Well, thank you so much for a most informative presentation. We're really glad to meet you, to learn all that you're involved in. I know your list is long, and hope that we can coordinate on lots of things from the standpoint of older adults in North Carolina.
Yeah.
And I know that Divya and folks at the division are hitting you up on the multi-sector plan on aging. So look forward to great things there. But thank the secretary for letting you come and talk with us, get a little pass from the retreat for a little while. So, but we appreciate you being here. Thank you so much.
He is crazy busy and pulled in so many directions. I'm delighted to be with you guys today. I'm really glad I was able to speak. So thank you.
So much.
Yeah.
All righty. Take care.
Thank you.
Okay, folks, so we're kind of wrapping up here. We're at the point where we've got announcements and sharing by coalition members. And I have one thing that just came in on the phone while we were talking, is that Social Security has announced their cost of living raise for next year. It's going to be 2.8%. So that's good to know. We had heard it was going to be somewhere in that range. So we're glad to hear that is what it's going to be. Anybody got anything going on you want to share? Meetings, updates? I think that a lot of the meetings that have fall meetings have already taken place, but Karen, I see your hand is up.
Sorry, I had to get my camera on. I just wanted to mention that the North Carolina Serious Illness Coalition Joining Our Voices 3-day symposium is next Tuesday, Wednesday, and Thursday from 12 to 1:30. I'll put in the chat the registration link for those who may not have signed up yet, but we would love to have as many people that are on this call at that event. It's virtual via Zoom, so I'll put that in the chat. Thanks.
Okay, great. Janice Tyler, if you're still on, do you want to say anything about the George Washington University series they've got going on right now that's free that people could participate in? Just saw Janice. Is she still there?
She's there.
I'm still here.
Yeah. Okay.
I
You
was
want to
trying
say
to
anything?
find,
Yeah.
I was talking and trying to find my mute button at the same time. I was like, so we have one more week. This is the Age Friendly Ecosystem Summit. This is with George Washington University's Center for Aging, Health, and Humanities. I've been working with them for a couple years now. And actually, AARP in North Carolina, Rosalie has joined our planning team. So we have one more next week. And they've been every Thursday afternoon for 1 to 3. And we have someone from the Attorney General's office of North Carolina speaking. I actually tried to get the Attorney General, but he wasn't available. We have taped all of these sessions. They've been really, really good. The first one was the state of aging policy. The second one was about housing. Yesterday, we talked about aging with confidence, with financial and social well-being. So if you want to, you can go out there and sign up, and then you can get the recordings.
Yeah.
Yeah.
It was really good. I listened to the first one because I had a conflict, but it was excellent and got the recording from it. So thank you for doing that.
Yeah.
And thanks for the announcement. Katie Kutcher, I see you had an announcement too. And you're on mute. Okay. Katie, can you come off mute? If not, I can read your announcement. Okay, it looks like she's having trouble. She wants to make sure everybody knows about, they've got a webinar on Medicare coming up on November 12th, and she has put a link in there. This is done through Central Carolina Council of Governments Area Agency on Aging, and she's got a link in there that you can sign up for more information on that. Anybody else got anything? Well, we don't have as many. Not as many announcements as usual, just because, like I said, I think a lot of things have already happened. And well, thank you guys. I think we're losing folks left and right because it is 12 and 2 hours is a long time, right? to sit. But appreciate everybody's engagement. Thank you to those of you who came to our annual meeting. It was great to see so many folks and great networking there also. But we look forward to seeing you. As you know, we combine our November and December meetings. So our next meeting is actually going to be on December Sandra, tell me when it's going to be. I don't have a note.
December the 5th.
December 5th. Okay.
First Friday this time.
Your first Friday in December at 10 o'clock. So look forward to seeing y'all. Thank you for hanging in there for 2 hours. I think we had great information exchange today. A lot going on. And, it looks like we're going to be for buckling our belts for a while here. So let's y'all stay the course here. But thanks all. Have a good weekend, and thanks for being involved. Take care.
Thank you, everybody.
Bye, y'all.